morning everyone. Myself Dr. Jayesh Prajapati, Professor and HOD Cardiology Department, UNMICRC Heart Hospital, Ahmedabad. Today I am going to discuss on recent advance in management of hypertrophic cardiomyopathy. We know that hypertrophic cardiomyopathy as a per se is not a new topic for our day-to-day practice as well as the management. So what is the definition of hypertrophic cardiomyopathy? So it is a disease state characterized by unexplained LV hypertrophy associated with non-dilated ventricular chamber in the absence of another cardiac or systemic disease capable of producing left ventricular hypertrophy. And most common it is a genetic cardiovascular disease, and prevalence nowadays because of so many other investigations, its prevalence is 1 into 500 and 1 into 200 if genetic and newer imaging modalities are taken into account. And of course, this is one of the important cause for the sudden cardiac death in young patients. And we have to rule out the other causes of cardiomyopathy, means you have to give the other causes of the LVS to be ruled out, like hypertension, aortic stenosis and all. So when we want to discuss the genetic, is a Mendelian trait, autosomal dominant inheritance, mutation in gene encoding the protein component of the sarcomere, and it constitutes myofilament element or the adjacent Z disc. Total 11 genes were identified. Most common genes are the beta myosin heavy chain MYH7 and another is myosin binding protein C MYBPC3. There are some other genes are also responsible like troponin T and troponin I related like TNN2 and TNNI3. And another important thing is management diseases are not determined genetic testing. So genetic testing doesn't determine the management things, but we have to discuss the severe course. We have to discuss with the families as well as the patient. So patient with gene positive patient than gene negative patient. So more severe course we can find in gene positive. In patient with thick filament mutation MYBPC3 and MYH7 compared with those with thin filament mutation like TNN2 and TNNI3. So these are some of the important things to be remembered, that gene positive patients, they do worse severe course compared to the gene negative, and some of the, as I have discussed, mutation they carry bad course. So these are the certain HCM genes as I have discussed: Z disc, intermediate filament, thin filament, thick filament, and lesser evidence of pathogenicity, and all these things as I have discussed. Another thing is which mutations. So beta MSC mutations present in the late adolescents and develop substantial hypertrophy and more severe disease. So beta MSC mutation we have to remember, and MYBPC3 mutation, delayed clinical presentation, age 50 or older, less severe symptoms. So later the presentation, not much symptoms, but earlier adolescent or the young presentation, they carry not a good prognosis. And CNTT mutation, increased risk of sudden death, and CNI, troponin I mutation, greater predisposition of apical hypertrophy. So apical hypertrophy with troponin I mutations, while troponin T mutation, they increase risk of sudden cardiac death. When we see the gender and race wise, it is seen almost both equal, male and female. Women progression to advanced heart failure. So women may more progress to more of heart failure, and phenotype in all the races, although some kind of variety like apical HCM is more common in the Japan continent. What is morphology? So there are morphologies like asymmetric septal hypertrophy with small LV cavity. Diffuse common is the 70 to 75% diffuse hypertrophy of the septum and anterolateral free wall. So posterior wall is spared while the septal hypertrophy and anterolateral free wall is hypertrophied. Another is only basal septal hypertrophy 10 to 15%. Concentric variety of SCM is also known, which a patient doesn't have got a hypertension, but they have got a concentric hypertrophy 5%, apical hypertrophy less than 5%, and only lateral hypertrophy, which is relatively uncommon 1 to 2%. So no single morphologic form of hypertrophic cardiomyopathy is considered classic or the typical. So we can see so many varieties. And other findings, what we can see as such, it's a LV hypertrophy, so we can find the subclinical diastolic dysfunction, and of course blood-filled myocardial scrapes, mitral valve leaflet elongation. So most of the patients of hypertrophic cardiomyopathy, because of same as well as related is morphology of mitral valve is different. So mitral valve leaflet elongation,
and collagen precursor biomarker and myocardial scanning we can see, and we can see the ECG abnormalities that I am going to discuss. So this is one of the autopsy specimen of hypertrophic cardiomyopathy. We can see the thickness of the septum, and we can see the thickness of the left wall. When it is presented, so sometime incomplete, it is SCM phenotype remains incomplete until adolescence. So we can see after 16 to 18 years, we can see that hypertrophy is more. So accelerated growth and maturation are accompanied by spontaneous increase in LV wall thickness, and occasionally these structural changes may not occur until midlife or even later. Sometime echo might be normal at the age of 20 or 25 or 16, and then later on the changes of the hypertrophy start, and we can see midlife after 40 or 50, we can see hypertrophy. So that can occur in hypertrophic cardiomyopathy. What happened to mitral valve apparatus? So there is elongation of both the leaflets, segmental enlargement of only anterior leaflet or mid portion of the posterior leaflet. So there is valve abnormality, congenital anomalous anterolateral papillary muscle produce muscle mid cavity outflow obstruction. So that leaflet and papillary muscle hypertrophy, and that is anomalous, and that can cause also obstruction.
So what we see here is histopathology. So histopathology is an important thing. There are cellular disarray. So hypertrophic cardiac muscle myocyte in both the ventricle septum and LV free wall, and arranged in a chaotic and disorganized architectural pattern. So histopathology, so endomyocardial biopsy, muscle biopsy is one of the diagnostic tool in case of hypertrophic cardiomyopathy. But nowadays in era of course the MRI, gadolinium scan, that nowadays biopsy is not utilized much more. So this is kind of things what we can see on histopathologically, that is normal myocardial tissue versus the hypertrophic cardiomyopathy. So there is myocyte disarray we can see. So these are the not normal muscle hypertrophy. And of course, when we see the coronary arteries also differently. So abnormal intramural coronary arteries, thickened wall and narrow lumen near to areas of replacement of fibrosis. Microvascular disease, silent small vessel, myocardial ischemia, then myocyte death replacement fibrosis. So there is fibrosis and thickened wall of the small arteries of the myocardium, and unstable electrophysiology is substrate. So there are, because of fibrosis, there are electrical depolarization, repolarization. So these patients are more susceptible for the ventricular arrhythmias like ventricular tachycardia. That's why the sudden cardiac death is one of the commonest cause of mortality in case of hypertrophic cardiomyopathy. What we see in pathophysiology, so there is a one thing is unobstructed variety or non-obstructive, another is the obstruction. So what we see is the LVOT obstruction. So it is produced by systolic anterior motion of the mitral valve and mid-systolic ventricular septal contact. So mitral valve comes into contact of the septum, and LVOT is obliterated, and it's a dynamic thing. So SAM is an abrupt anterior motion of the mitral valve in which elongated leaflet move towards the septum with a sharp angle 90-degree bend. So abnormality of mitral valve as well as the septum, both things are important. And it's a drag effect, pushing force of flow directly on the leaflets, and that can cause the mitral valve and septal contact is there. Whenever the dynamic gradient of 30 mm Hg or more, either at rest or with physiological exercise, then it is known as LVOT obstruction variety. And there is only a weak relationship has been demonstrated between outflow obstruction and sudden cardiac death risk. So obstruction doesn't carry that. So very severe obstruction is a different issue, but always not like that the obstruction, then the risk of sudden cardiac death, that we have to keep in mind. So in the classic form of obstruction at the most basal portion, what we see, classic form, most basal portion of the septum, there is obstruction we find. So LVOT at the basal. So hypertrophy and basal contact comes, then it occurs. So congenital anomaly, another what we see is the papillary muscle abnormality. So anterolateral papillary muscle insertion directly into the anterior leaflet without interposition of chorda can produce mid-cavity muscular obstruction and is identified by both echo and CMR. So cardiac MR and echo both are helpful in such situations. So the magnitude of the outflow obstruction is directly related to the duration of the mitral valve and septal contact. So it is related to how much time it remains into the contact, it decides the obstruction. So this is one of the important things. This is how it demonstrates. So obstruction is dynamic, varying with loading condition and contractility, increasing it with VPC, and we can see that dobutamine, isoprenaline. So when we do the exercise, these are some of the provocative tests. And another is that dynamic auscultation, what we learn in clinical cardiology, like what we see amyl nitrate inhalation, nitroglycerin, Valsalva, and sometimes what happens whenever the LV cavity is small, like dehydration, inotropic agent, this can increase the more contact and that increases the LVOT gradient. So alcohol increase the obstruction. So what we see sometimes we have seen that it produce alcohol ingestion and sudden cardiac death in SCM patient is also non-thing. So alcohol, heavy meal and alcohol both increases the obstruction. So that we should keep in mind. So how we can reduce the obstruction? So we should reduce the contractility. How we can reduce the contractility? So we should use the negative inotropic drug like the beta blockers. And another thing is that increase the ventricular volume or the arterial pressure. So sometimes what we have to give IV fluid. That is one of the important thing, and skating and all these things. So how the dynamic LVOT obstruction we can grade it? So basal obstruction condition is the rest, outflow is 30 mm, non-obstructive is less than 30, obstructive is more than 30 with provocation, and labile obstruction is at the rest is less than 30 and physiological provoke it increases. So which are the provocation things? As I have told that provocable physiological gradient may present with severe heart failure, patient sometimes non-obstructive heart failure, provocable gradient, but they can go into the progressive heart failure, and this can be provocable gradient is also important thing, sometimes requires septal reduction. So how many percentage of patient, group of the patient? So non-obstructive, provocable obstruction and rest obstruction, and see the rate of progression to the heart failure. So see that patient non-obstructive, they are 1.6% per year, provocable obstructive 3.2% per year, while the rest obstruction 7.4% per year, they can progress to the heart failure, progressive heart failure, that we have to keep in mind. So non-obstructive hypertrophic cardiomyopathy, gradient less than 30 at rest and with physiological exercise, almost 5 times less likely to develop NYHA class 3 or 4 disease that a patient with the obstruction. And factors determine the passive elastic properties of the LV chamber, such as hypertrophy, replacement scarring, interstitial fibrosis, abnormal microvascular blood flow and disorganized cellular architecture. So muscle is abnormal. So obstruction is not always important. The muscle abnormality and that muscle, that fibrosis and everything. And this patient have got a diastolic dysfunction and sometimes they refractory to medical management. So such kind of patient, even the hypertrophic cardiomyopathy, non-obstructing, going for an NYHA class 3 or 4 failure, they are also candidate for the heart transplant. So heart transplant is one of the indication in case of SCM. What? Because of hypertrophy, we can see the diastolic dysfunction. So it's an impaired relaxation and filling of the LV, and it of course causes diastolic heart failure. Rapid filling is of course affected. Compensating increase in the atrial filling. It can lead to the arrhythmias, also atrial fibrillation, and reduced ventricular compliance in case of hypertrophic cardiomyopathy. And important is the microvascular dysfunction. As I have told, because of hypertrophy, coronary abnormality, and this kind of microvascular dysfunction we can detect more most importantly in case with PET. So position emission tomography is the technique most useful for assessment of microvascular dysfunction. So one thing we have to see is the obstruction, hypertrophy, of course the symptoms, and then comes the regurgitation. So mitral valve regurgitation secondary to distortion of mitral valve apparatus because of SAM, and jet of MR is directed laterally and posteriorly and predominantly during late mid systole. So this MR we can see during the late and mid systole, and there is a central or anterolateral directed mitral regurgitation jet usually suggests an interesting mitral valve abnormality compared to myxomatous degeneration, and of course it is severity proportional to the LVOT obstruction. Another thing we see is the autonomic dysfunction. So abnormal blood response to the exercise. When you do the exercise, if the blood pressure falls, it is a bad sign. So that we have to keep in mind. So abnormal blood pressure response to exercise defined as failure to increase the systolic blood pressure by at least 20 mm mercury or a drop in systolic blood pressure during exercise is associated with poor prognosis and increase the risk of sudden cardiac death. So if the duration during the exercise, if the BP doesn't rise or it fall, it is a ominous sign in case of
cardiomyopathy. Which are the symptoms we can expect in case of hypertrophic cardiomyopathy? So majority are asymptomatic. When we see on a screening, as a family screening, we can find it. Dyspnea is the commonest. 90% of the patient, they complain of shortness of breath. Syncope and pre-syncope in 20 and 50% respectively due to either hemodynamic abnormality or rhythm abnormality because of either ventricular tachycardia or atrial fibrillation or hemodynamic abnormality because of obstruction. Another is the angina. Angina occurs because of not only only coronary artery disease obstruction, but it is because of small artery narrowing, intramural compression of the small arteries, and of course the supply-demand mismatch as occur in case of aortic stenosis, abnormal coronary flow reserve. Another is the palpitations. We can see the symptom because of either atrial fibrillation or because of ventricular ectopy because of that myocardial disarray and some of the scarring or the fibrosis. And it is we can see more arrhythmias or the VPC after large meal and heavy alcohol ingestion. So what we expect on physical examination? So physical examination is good thing. We have to see the peripheral pulse, arterial pulse also can give idea. We have to see the carotid pulse is brisk with spike and dome pattern. That is important because of LVOT obstruction. So rapid rise followed by mid-systolic drop followed by secondary wave. So percussion wave, tidal wave, it is pulsus bisperiens and spike and dome pattern. And apical impulse, we can see that double or triple apical impulse we can see, and there is a paradoxical split in 20% of the cases, and there is a fourth heart sound we can find because of diastolic dysfunction, because of LV hypertrophy. The atrial kick is more because of these things. What kind of murmur we can expect? Here the role of the dynamic auscultation I am going to discuss. So murmur, we can see the medium pitch, ejection systolic, crescendo, decrescendo at left sternal border, and varies in intensity with the magnitude of the subaortic contact. So whenever there is a gradient is more, it can murmur severity will be more. It radiates to the base as well as to the apex, but doesn't go to the carotid. A loud murmur of at least grade 3/6 are likely to have LVOT of more than 30, gradient of more than 30. And dynamic auscultation, maneuver that decrease the preload will increase the dynamic gradient and increase the intensity of murmur, like standing or the strain phase of the Valsalva. So we know that dynamic auscultation carries role in case of MVP and hypertrophic cardiomyopathy. How we can differentiate from fixed aortic stenosis? Of course, the murmur radiate to the carotid in case of AS, and of course the variability of the murmur and location of the murmur, that makes a difference in case of HOCM compared to the aortic stenosis. What is natural history? It can present at all the age of life, from infancy to the old age, and adverse outcome seen in what is adverse outcome? So sudden and unexpected death, progressive heart failure with exertional dyspnea and functional limitation, and arrhythmias like repetitive, persistent or permanent fibrillation, and the risk for the embolic stroke. So patient can progress, some of the patient of the hypertrophic cardiomyopathy, and later on go to the dilatation of the LV cavity, then the obstruction goes off, and that is a worst sign. So patient develop LV dysfunction and develop ejection fraction less than 50%, that is considered as a heart failure. And this occurs because of small vessel mediated myocardial ischemia and diffuse scarring. And these patients are not good patients, and they should be treated as per the heart failure guidelines, and such kind of patient requires heart transplant, that we have to keep in mind. So which are the burnt out SCM? As I have talked, 3% they manifest at end stage systolic dysfunction, ejection fraction less than 50. Here not the EF less than 40, 45 like that. So usually hyperdynamic, most of the patients of the hypertrophic cardiomyopathy has got ejection fraction around 70%. They are hyperdynamic. Progressive heart failure often associated with atrial fibrillation, and that is a pattern of LV remodeling, and then gradually the wall thinning, the gradient comes down and cavity becomes dilated, and that is because of transmural scarring, and patient can progress to refractory heart failure or sudden death. And most reliable risk factor for evolution to the end stage is family history of end stage. So some of the families, they have got a family history of end stage heart failure, they develop more heart failure. So one cause of death in hypertrophic cardiomyopathy is a heart failure related things. Another important is a sudden cardiac death, may occur at any age. Most commonly adolescent and adults less than 30 years of age.
unpredictable, significantly less common in patients 60 years of age or older. Suppose patient become aged, then the chances are less. Maybe the initial clinical manifestation of the disease in asymptomatic patient. Patient comes with a history of syncope or survival of the sudden cardiac death, and most common during the sedentary or modest physical exercise. So that is important thing. They either can occur at rest or during the modest exercise can occur. And this is one of the cause for the young athlete death. So how we get secondary prevention? So patient who are the survived sudden cardiac death or patient who have found Holter arrhythmias are there, then patient the ICD should be implanted. So patient with a secondary prevention, the ICD should be implanted. What for the primary prevention? So primary prevention is the patient got a family history of one or more premature SCM related death, unexplained syncope, especially it was a recent, a hypotensive or attenuated blood pressure response to the exercise, multiple or repetitive non-sustained VT, massive LVH, if the LV wall thickness is more than 30, such group of patients, the primary prevention ICD should be implanted. And what kind of abnormality we can find on ECG? So it is found in 90%, 95% of the SCM patient and 70% of the asymptomatic patient, we can see ECG abnormality. Not a pathognomic. So sometimes we can see the abnormality in subarachnoid hemorrhage. So not a pathognomic, but if there is ECG changes and echocardiography, both correlate, that is the important thing. And increased voltage consistent with the LVH seen in 70 to 80% of the patient. We can see the LVH by voltage criteria in case of SCM or the hypertrophic obstructive cardiomyopathy. There are STT changes we can see, LA enlargement, deep and narrow Q wave, disturbance of activation of the ventricular septum, diminished R wave in the lateral precordial leads, and apical SCM that is found in Japan, diffuse symmetric T wave inversion across the precordium, and we can see the atrial arrhythmias or atrial fibrillation in 25 to 30% of the cases because of diastolic dysfunctions. So these are this kind of abnormality we can find more commonly in case of hypertrophic cardiomyopathy, like deep symmetrical T wave inversion, LV criteria, LVH, left atrial deviation, atrial arrhythmias, or such kind of things we can find. And one important normal ECG pattern are more commonly associated with mild LV hypertrophy favorable clinical course. Suppose someone has got a hypertrophic cardiomyopathy, ECG is normal, that is a good thing, it's a favorable clinical outcome. And increased voltage is tall R wave or deep S wave are only weakly correlated with the magnitude of LV hypertrophy. Usually the LV hypertrophy doesn't correlate much more with the ECG criteria. Important diagnostic tool what is available easily is echocardiography. It confirms the LVH, it associated with LV obstruction you can see, SAM you can assess, and systolic and diastolic LV function LA size you can assess by these things. So how we can confirm? So we have to see the unexplained maximal wall thickness more than 15 mm in any abnormal, any myocardial segment. So suppose septum thickness is 15 mm, other thickness is low, then we have to suspect. Septal to posterior wall thickness ratio more than 1.3 in a normotensive and more than 1.5 in case of hypertensive. So that is we should keep the criteria in mind. So this is the things. So hypertrophy you can see on echocardiography. See here, the septal hypertrophy, here the septum is thick, while see the posterior wall is not thicker. And these are some of the variety of the LV morphology in case of SCM. Sometimes we see sigmoid separate septum, S separate septum, where the basal septal hypertrophy is more, reverse septum, mid septum is bulky like fatty, neutral septum, whole septal hypertrophy, apical variety of SCM where the only apex. So see the variety. So most common variety we can see the reverse septum is 79%, while we see sigmoid separate septum in 8%, and another is a neutral septum, whole septal is hypertrophy, and the posterior wall is normal. So such kind of things when we see on echocardiography, we have to suspect is that this is the commonest variety of hypertrophic cardiomyopathy, what we see in our day-to-day practice. Another importance we have to see SAM. SAM is because of a DREV, it's a Venturi effect, and factor contributing the septal encroachment into LVOT, mitral morphology different, anterior displacement of the papillary muscle, unusual caudal attachment, and elongation of anterior leaflet. So obstruction is more likely to be present when the mitral leaflets makes direct contact with the ventricular septum for 40% or more of the systolic cycle. When the 40% or more of the time the mitral valve comes into contact of the septum, then it causes significant gradient. So this is how the SAM we can see. Is a M mode LV cavity. We can see the SAM
This is very clearly shown by the arrow, the systolic entry motion, and more than 40% of time it remains in the contact, it causes significant gradient. So this is the how we can see the SAM, and these are the how we can predict the gradient also. We have to see that Y interval and X interval. Y interval from the beginning of SAM to the SAM septal contact, another is the how much time it remains in the contact, that is how we can find out the gradient also. Another thing is what we can see in the M mode is aortic valve notching, because the cardiac output drops. So output tract obstruction occurs mid to late systolic occurrence with late phase of LV contraction. The reduction in flow volume result in partial closure of the aortic valve, and secondary opening as a final ejection occurs. This is a single notch or occasionally severe discrete high amplitude notches like vibrated we can see on a M mode of the aortic valve. So we can see such kind of notching in a M mode in case of hypertrophic obstructive Cce. There is a notch shown by arrow that we can see in such cases. So MR is also seen. So failure of normal leaflet coarctation lead to mid to late systolic MR, and LVOT jet is narrower than MR, and best 2D echo LVOT gradient apical 3 chamber. But what we want to see the LVOT gradient, we have to see the apical 3 chamber. We should not mix with the LVOT gradient, MR, aortic stenosis. There's three things we have to keep in mind during the echocardiography. So Doppler echocardiography, so dynamic LVOT, we can see the high velocity dragger shape signal. So that I am going to show by image. So how the dragger shape, that is the LVOT gradient. And low output tract velocity less than 3 meter per second, provocation with the Valsalva or inhalation of amyl nitrate or exercise determine a labile or lateral obstruction. So Valsalva can help during the echocardiography. So this is a dragger shaped. We can see in obstructive cardiomyopathy, mitral valve more or less triangular in case of aortic stenosis, while the mitral ligament is more or less rounded, opposite rounded signal. We can see how we can separate it. Aortic stenosis, MR, and obstructive cardiomyopathy. So this is how things looks in a echocardiography. So dragger shaped, late obstruction, and of course the MR signal also like this, density of the signal also differs, and the location of the signal, how we put a Doppler cursor, that also makes a difference. So dynamic LVOT obstruction doesn't mean that always a HOCM. We can see mid cavity obstruction in so many situations in ICU setups. So we can see, suppose patient is a hypovolemic shock where the LVOT is small, we can find. We can find in case of hypertension also, when a narrow cavity, mitral valve prolapse also, acute, sometimes what happens in MI, like balloon, apical ballooning, we can see mid cavity obstruction. In case of acute anterior apical MI, where you can see there is basal septum obstructing, and patients who are treated with a vasodilator and very volume depleted status, as I had told, patient too much on inotropic uses, we can see such kind of dynamic LVOT obstruction. Another thing, we have to look for the LA volume as well as the LA size. So LA volume assessment can also be done in case of SCM. Another thing, we have to see the relaxation finding. So tissue Doppler is also important. These are the things to be looked for the mitral septal systolic annular motion, SA less than 9 centimeter per second. So these are some of the Doppler criteria, tissue TDI, that can decide that patient has got a diastolic dysfunction. So another variety we can see mid LV obstruction, SCM. So we can see the mid cavity obstruction where the maximum hypertrophy at the papillary muscle level, and we can see the mid cavity obstruction. Also, this is one kind of things we find that is known as lobster claw. So these are the lobster claw where there is a mid cavity obstruction, where the more hypertrophy in the mid septum, then the mid septum comes into contact when we see the lobster claw. So that is something different that we should keep in mind. We have to assess the diastolic dysfunction because of that stiffness of the LV cavity, that we have to keep in mind. So after echocardiography, another important tool is the catheterization. So we have to see the pullback gradient. So when we want to separate out with aortic stenosis, then we have to put a catheter into the LV cavity. We can take a end hole and side hole catheter, and we have to track down from the LV apex to the mid cavity, LVOT, and above the valve, when we can decide the gradient between LV cavity and LVOT. So that is how, but there can occur the catheter entrapment because of hyperdynamic. We can find, ideally the measurement should be done with a
doing the septal puncture, we have to go into the LV and another catheter into LVOT. The direct things can also be done, but it is very cumbersome. So one thing is that we have to see the pullback gradient from LV apex to LVOT to the aorta. So that is how we can see. So such kind of thing we can find where the gradient is. So we can separate it out whether it is a subvalvular, HOCM, valvular obstruction or supravalvular aortic stenosis. And another thing, this is how we should do the pullback gradient. This is what everyone is asked in their exam. This is the Brockenbrough phenomenon. So post VPC, there is exacerbation in the contractility. So this is a Brockenbrough phenomenon. That is also one of the CAT tracing which is asked in the exam. So once you do the VPC, then the next bit what happens, that is known as the Brockenbrough phenomenon. Another, when we do the LV angiography is also important. When you want to assess the septal hypertrophy, ideally two catheters should be put on, one is the LV cavity, another RV cavity, and we have to see with two injector we can assess both injector, the simultaneous LV and RV angio in LAO view. We can assess how much septum is hypertrophied, or simply by doing the LV angiography in LAO and RAO view, we can see that what we can see the hyperdynamic LV total obliteration of the LV cavity, and we can see the SPAD-like configuration in case of apical HCM. So this is how we can see whole LV cavity is empty in systole. So that is almost we can see the ejection fraction more than 70 or 80. Or we can see this apical ballooning kind of things. What we see in case of apical hypertrophic cardiomyopathy, we can see the papillary muscle also in case of hypertrophic cardiomyopathy. Another, as I told, we have to see by the stress testing, Valsalva manual, hand grip, amyl nitrate, and these are the things we can differentiate. We can increase the gradient by Valsalva manual as shown in this image. What is another important tool is the MRI. Cardiac MRI is one of the important things. More accurate than echocardiography, can detect 6% or more hypertrophy, and accurate measurement is the thickness, dynamic LVOT obstruction, and late gadolinium enhancement. This is for the myocardial fibrosis. That is what is the important thing for when we want to see for primary prevention, secondary prevention, when we want to use ICD implantation. So MRI is one of the important tool in case of hypertrophic cardiomyopathy. So which are the poor prognostic criteria on MRI? So mark elevated mass index, men more than 91 and women more than 69, sensitivity 100%. So LV mass index is more than poor prognosis. Maximal wall thickness of more than 30 millimeter, that is specific for 91% of the cardiac deaths. RV hypertrophy, myocardial edema by T2-weighted, we have to see the late gadolinium enhancement, that is important for ventricular arrhythmias and progressive ventricular dilatation. So that is how we can see the septal hypertrophy. By arrow, this is how much the septal is hypertrophied, and see the gadolinium enhancement also we can see in this. These are the gadolinium enhancement. See, there are arrow has shown there is a apical variety of hypertrophic cardiomyopathy, and we can see that there are late gadolinium enhancement, and that is important thing to decide the prognosis. And what is nowadays endomyocardial biopsy is not done routinely because we have got other important tools available like MRI, echocardiography and all. So endomyocardial biopsy may be considered when the result of other clinical assessment suggests myocardial infiltration, inflammation or storage that cannot be confirmed by other means. Suppose when we are suspecting the other pathologies like sarcoidosis or some of the infiltration amyloidosis, infiltrative cardiomyopathy, when we cannot differentiate it by other means, then only is a 2B indication for endomyocardial biopsy. So how we can differentiate between athlete heart and SCM? So SCM can be asymmetric, while the athlete heart is concentric, wall thickness is less than 15, LA is more dilated in case of SCM, while less in athletic heart, LV and diastolic dimension is less than 45, while athlete heart is more dilated heart, and diastolic function is always abnormal in SCM, while it can be normal in case of athletic heart. Where family history, this is one of the important things, family screening when should be done. So it is to be done by 2D echocardiography, CMR and 12-lead ECG in addition to history and physical examination. It should be performed on 12 to 18 month basis, and it should be started as age of 12 years. So these are some of the guidelines This you can find on a net also. So age less than 12 years, 12 to 21 years, follow-up should be at 12 to 18 months, and age more than 21 years, imaging at onset of the symptoms, or possibly at 5-year interval, at least from midlife. More frequent interval for imaging are appropriate in families with malignant course or history of late onset SCM. So earlier presentation, we have to follow up them very closely. Late presentation, at least as I mentioned in this slide, you have to do it. So how we can manage such kind of cardiomyopathy patients? So we have to risk stratify the patients. So sudden cardiac death is one of the important thing. So ICD for primary prevention is 4% per year prevention. Second is 12% per year. And it can prevent the progression. Subcutaneous ICD or whatsoever ICD you want to implant, you have to implant. Amiodarone is obsolete and uncertain efficacy. Side effect of long-term use. Amiodarone should not be used routinely. And another patient, suppose he had got an atrial fibrillation or some scarring, then EP opinion should be taken, and if ablation is possible, VT can be ablated, but is it useful in patient with LV apical aneurysm only? So these are the patients where the ICD to be implanted. So these are the highest, intermediate and lowest. So secondary prevention, of course, yes. For primary prevention, patient who got family history of sudden cardiac death, unexplained syncope, we have to do the Holter monitoring repetitive, there are episode of NSVT, abnormal exercise response, BP response, suppose hypotensive response, and massive LVH more than 30, then patient should be put on intermediate criteria, that should be put on for primary prevention. And potential arbitrator like end stage, LV apical aneurysm, mark LV outflow obstruction at rest. So only outflow obstruction doesn't mean that we have to implant it. And after septal ablation, then CHB developed, then better to implant a ICD. And some of the patient who are intense competitive sports player, then it can be put, and CAD patients. So which are the drugs to be used? That is one of the important things. So all the patients, not ICD. So important drug is the negative inotropic beta blockers. Propranolol, metoprolol or atenolol can be given in a full dose up to, we can say, 200 to 400 milligram. And it is helpful for decreasing the gradient, decrease the exercise gradient, improves the diastolic dysfunction. We have to see for the hypotension, bradycardia and bronchospasm. Another calcium channel blockers, first is verapamil, second is diltiazem. We can go up to 240 milligram. We can prepare a long-acting preparation can also be used. When we combine with a beta blocker, we have to be very careful. So first is beta blocker, second is calcium channel blocker. When we combine both, we have to be very careful. If patient is not responding to this, then either disopyramide is one of the good molecule, 100 milligram twice a daily, we can increase to 600 milligram, and we have to see for anticholinergic side effect, and we have to see for the QT interval also. Another newer molecule has been studied is a mevacamtan, and this molecule has been studied, and it is shown that in long run it is quality score as well as it decreases the LVOT gradient, and this is one of the negative inotropic drug. Mevacamtan has been also one of the good drug, has been investigated in these studies in hypertrophic cardiomyopathy patient. This study, Maverick SCM study, has shown the positive result of mevacamtan. Another molecule was renologin. Patients suppose having ventricular VPCs or ventricular tachycardia, or the patient ill-sustained VT, this the molecule can also be given. Another is the surgical things. So septal myomectomy is one of the important things that is known as Morose procedure, and that decreases the gradient, where there we should see the criteria. Patient is symptomatic, dynamic LVOT gradient more than 50 and associated with septal hypertrophy, and there is a mitral valve abnormality, then surgery is always the best thing, it should be carried out. And transaortic rejection, more is a transaortic rejection, 3 to 10 gram of muscle is removed, operative mortality less than 1%, and improves the survival of sudden cardiac death, reduces the MR also, and of course carries some risk of LV dilatation and some risk of bundle block, and of course complete heart block, and when ventricular septal defect. So these are some of the side effects. Another tool that we can see is the septal ablation, but whenever the LBBB we should not do it. So septal patient, if those who are, this is a class B indication. So when the patient has contraindication to the surgery, then this is one thing we can see the large septal artery, and that is to be ablated with alcohol. So that is can cause a scar into the septum, and we have to assess by echocardiography. We have to do the contrast echo, And we have to say that during the in the cath lab, we have to ablate, or we have to put alcohol carefully into that particular septal artery. The spillage should not occur into the LAD, otherwise we can develop with the entry wall MI. So that is important thing during the septal ablation, and these are the indication. So patient should not have got a coronary artery disease, compatible septal perforator branch. So that septal perforator, we have to identify that particular septal artery, and of course patient contraindication to surgery, and patient is not ready for surgery. Which are the contraindications? Suppose patient got a mitral valve disease or CAD requires CABG, extreme hypertrophy is not used, and complex abnormal submitral apparatus, then this should not be done. And it carries a 10% risk of complete heart block requiring the pacemaker implantation, and then spillage can cause MI, that we should keep in mind, and coronary dissection and all these things. Another tool is the DDD pacemaker. So whenever patient has a contraindication, all these things. So patient got objective measure of exercise capacity did not differ significantly. So this is after surgery, that is the second choice. We can put a DDD pacemaker implantation, that can we can delay the AV delay, we can set it, and accordingly the gradient can be separated out. So dual chamber pacemaker is also one of the important tool. ICD, as I have told, these are some of the indication, class 1, class 2 already I have discussed. And if the patient got atrial fibrillation, then of course this patient should be anticoagulated. Here the CHET to VAS score is not validated for SCM patient, but occur in 20 to 25% of patient. Amiodarone is the most effective in reducing the recurrences, and beta blockers in verapamil to control the heart. So we should give the beta blockers and verapamil to control the heart rate. And of course the catheter ablation can be done in case of what a drug refractory or unable to take the antiarrhythmic drug, then it should be done. So SCM patient, how we should go ahead? So patient echocardiography should be done. LVOT at rest or with exercise should be assessed. Asymptomatic, no treatment. Mildly symptomatic, medical treatment. Drug refractory, severely symptom, class 3, 4, surgical options like surgical myomectomy, alcohol septal ablation. And another thing is, if there is non-obstructive, at rest, asymptomatic, no treatment, mildly symptomatic, medical treatment, and patient with a heart failure, non-obstructive, always we have to give guide-directed treatment for the heart failure, and they are not improving, then they should go for a transplant. So that is important thing that we have to keep in mind. Genotype positive, phenotype negative, these are the criteria you can find on ACC/AHA guideline, and of course the AF and stroke prevention, we have to give them proper anticoagulation, and we have to treat AF. And this is what I want to say for hypertrophic cardiomyopathy. Thank you so much for your attention.